as I said, I'm at University of Birmingham. That's the picture you see on the right-hand side. And on top of being academic, I also hold honorary consultant positions with UHB and UKHSA. I also chair the data work stream for the West Midlands Secure Data Environment. I do global work, mostly in Sri Lanka, where I come from. So I hold a honorary professorship there. But I also work for a social enterprise, unpaid, as medical director, creating computable guidelines called openclinical.ci, openclinical. But more, I will be talking more about DEXTER today, a tool we developed here in University of Birmingham. So the title of the talk is about democratizing health data research for better care. I'll go into explaining what we mean by that. So this is the center we have created here in University of Birmingham. And you can see across that there are two key things. One, we wanted to bring a large number of methods in one place. So the type of work I do is to do with clinical epidemiology, computer executable guidelines, data-driven clinical trials, whereas the work my colleague does is mostly around AI, bioinformatics, and so on. So we wanted to bring plenty of methods, but also we wanted to enable data, not only clinical data, but also bioinformatics data. This is the omics and genetics data. So for that purpose, we created this center here at University of Birmingham. So when we say the area I work is very much along with electronic health records, and we tend to call it real-world evidence. I'll first give you 2 or 3 examples, and then talk through how we use technologies to do this type of research. So this is a simple study published 2-3 years ago, where, for example, in hypothyroid patients, if you are giving thyroxine, at times the main aim is to bring the TSH levels between normal levels, which is usually around 0.5 to 4. However, many endocrinologists were wondering, should we keep it between 0.5 to 2 or 2 to 3 or 3 to 4? Should we get more control as such? And this is something you wouldn't do a randomized control trial, because you won't be randomizing people to bring their TSH levels into different category to look at mortality, cardiovascular health, because one, the drug is cheap, no one is going to be interested. Second, of course, it's long-term outcomes. What we were able to show is that I'm only showing mortality here, irrespective of what the outcome is. As far as you keep it within normal range, then the outcomes are similar, which means if it is higher or lower, then the mortality is higher. This is where we are evaluating a new policy. This is in pregnancy. Previously, people used to give IV antibiotics in a cesarean section once they have clamped the cord, which meant the antibiotic never reached the baby. Now what they do, after a trial, they give the antibiotic at the time of incision to reduce infections. But that means obviously the antibiotic will cross and get into the baby. So people were worried it will alter their gut microbiota and thereby predispose them to future allergic disorders. What we were able to show, I won't go into the detail again, that sort of adverse events was not going to happen. This one published last week in Nature Medicine with our cardiology colleagues. Usually atrial fibrillation, we tend to anticoagulate people with a higher risk, usually CHA2DS2-VASc score 2 or more. But we all know that even at low risk of atrial fibrillation, these patients are at high risk of getting vascular dementia, ischemic heart disease, stroke, and mortality. So based on this evidence, actually now there is a trial going on called DEXTER, where they are actually providing anticoagulants, the NOACs, to people at low risk. But that is actually 3 examples. What we have published in the last 5 years is more than 150. Okay. Before 6 years ago, we will probably publish 1 or 2 papers in a year. So what made it possible for us to do so is what I'm going to talk through, and why we as a region, if we were to embrace these sort of methodologies and technologies, why we as a region can do it. But more importantly, what we mean by the democratizing health data research is, why can't we get every single health professional, nurses and midwives, to do research? Because at the moment, the reason they don't do is, 1, they don't have the time. 2, they just don't have the technologies or access to data. And thirdly, of course, they also need to learn certain skills as such. But if you look at the questions, the question that should we anticoagulate people at low risk who have atrial fibrillation, I'm sure every single medical student, even the patients, ask that question. We don't need a cardiologist to ask that question. So this is where we believe that every general practitioner to every health professional should be able to generate questions, and there should be a mechanism to support them to do those research. It's not only research. The same tools can be used for quality improvement. The same tools can be used for trials. The same tools can be used for many other purposes as well. So these are the types of data we work here at the University of Birmingham, largely primary care data, but we have worked with hospital data. In fact, my MD comes from a hospital data at UHB. We now work a lot with maternity data. We have just started around mapping 150 tables of BAGNet data, but we work with other maternity data as well. And if you take a typical primary care database, this is one of the smallest databases, so it's 18 million patient records. And as you would imagine, there are billions of data points with so many millions of prescriptions, blood results, diagnostic codes, and procedure codes. If we were to do a study within this database, there is a number of problems, because obviously it wasn't collected for research. There are numerous biases. So typically in epidemiology, we'll call this prescription by indication bias, immortal time bias, and numerous other biases that occur. So when I develop a study design, for example, a matched cohort study design, where, for example, I want to compare people with polycystic ovarian syndrome with women who do not have polycystic ovarian syndrome, and look at their long-term outcomes, there is a way I will create that data set. So from what we call research-ready data sets, I will create what I call analysis-ready data set. And this takes us months to get into that millions of patients, ensure we correctly identify the index state they were exposed to a particular exposure, to ensure that at the same date, we assign the index date to the control population, collect all the baseline at that time point. People will write scripts and then pull the data. And it usually, by the time I ask from a primary care data, the expert will bring it to me in 3 to 6 months. And if I ask 10 different people, they will give you 10 different data sets. And even if I ask the same person twice, 3 months apart, they will give you 2 different data sets. So this has been a huge problem and very costly. But on the other hand, I'm a firm believer. People say it's dirty, the data we have in electronic health record, but just like what you see on the left-hand side, fractional distillation, if you know how to manage that particular data, then and filter it in a way, it is not the most purest LPG gas that runs plane or anything, but it's knowing how you use that data. And likewise, if you understand the data and process it well, it can be used for many things. And this is where, as a public health physician, I just need some information that is sufficient for action to improve population health, for you to improve individual patient care. It doesn't have to be something that will satisfy my intellect on my academic side as such. So this is where the problem is. We usually put a question, proposal, and when it comes to extracting data, it takes time. And this is the technology we created over 6 years called DEXTER. So what is DEXTER? Essentially, we have knowledge engineered epidemiological study designs. Let it be cohort study. So Krishna Gokhale, the computer scientist who created, now he has a team of 10, 15 people. Essentially, you can do cohort studies, case control studies. You can do complex studies, what we call new user design for comparing drugs, or even more complex studies called prevalent new user design for pharmacoepidemiology studies. This meant what used to take 3 to 6 months can be achieved within 60 minutes. So some, of course, if it's very, very large data sets, it takes more time. But as far as you have got your phenotypes defined using another tool we have a clinical coding team, then things suddenly shorten from 6 months to 60 minutes to 6 hours sort of range. And that meant naturally what meant 2 people can work on meant 20 people can work on it. 30 people can work on it. Teams grew rather than people felt, oh gosh, it's going to replace what humans do. No, actually what it did was it enabled more people to do research. Actually, the people who extract data, they are highly skilled people. They don't like just doing this sort of extraction. They are more able to focus on much more important things. So what is DEXTER? Recently, of course, it is being actually, last week, Krishna, the computer scientist, got a grant from Innovate UK to spin it out. What it means is it's a software not only can process primary care data, now it can also process other data. So it's data agnostic. Second thing is you don't have to bring your data to us. We can bring the software to you. It is multi-tenancy, which means your data will remain with you only. And within that, you can make sure who can access it. And even within them, you can assign them who will be able to actually download the data as opposed to people who can only visualize certain things. We are also building automated analytics, so you don't even have to do the analysis for simple questions that are used for quality improvement purposes. So over the last 5 years, this, of course, meant from a group of 3 people, the teams have grown into 30 and millions of pounds in research and publication. And more importantly, supporting junior colleagues. So Jot Chandan was a foundation doctor who came to me. I asked him what he really likes doing. He said he wants to do child protection and domestic violence related research. He is actually a police detective as well as a doctor, so the only police detective doctor across the country, I think. And he did his PhD while doing his foundation year and his next 2 years. And now he's senior lecturer last year appointed. And if all goes well, he'll become the youngest professor in University of Birmingham ever this year. So he's published, he's been in BBC, and he's not the only one. There's lots of people we have enabled from all different age groups. Some of them you might recognize as your colleagues. Probably Tanya will recognize Anthony. He's a nephrologist. He came as a ACL. We supported him getting his first grant as principal investigator. He's still running with prediction models for chronic kidney disease and dialysis need. Punit is a diabetologist, Jonathan is a diabetologist, and there are others, methodologists. Sajad did his PhD after retirement at 65, and he's got his first grant to look at predicting eye disease in hospital settings. But we have also supported our good clinicians. Ed will obviously know Nigel at Sandwell. So he runs a gastroenterology group, which we supported, and now he's created so many PhD students among the gastroenterologists and done a huge amount of research as well. And we have supported quite a few other specialities as well. So from a time where only 1 or 2 people can do research, there's a lot of people who can do research. Now, moving on to the secure data environment, which is led by, of course, led as individuals, Simon. Most of you know Simon. Simon Ball, who is the Senior Responsible Officer for the SDE, but it's not a University Hospital Birmingham thing. It's hosted by University Hospital Birmingham, but it is a West Midlands facility. And what this enables is all of you to bring your data into a secure data environment, and then there's funding to support you to process those data, and then of course to make that available for research. All the ethical approvals has been obtained, led by Professor Liz Sapi. So how are we hoping to work with the secure data environment? Of course, if you bring the data in there, they do have a license to use the DEXTER, so they'll put the data within the DEXTER platform. So people who come in, junior doctors who want to do research, for example, can access the data better without having to process them hugely. Or you might decide, no, we are not going to contribute the whole hospital data to the secure data environment. For those, of course, you can work with DEXTER to create it within your own hospital environment. And based on a requirement for specific question, you can contribute just that small part of the data to the secure data environment. But what we also recognized is that these technologies can be used for many other purposes. One that I'm passionate about is implementing learning health systems within different hospitals and primary care settings. I don't want to take too much time, but essentially learning health system is putting knowledge into practice, practice into data, and data into knowledge. So what that means is existing knowledge like clinical guidelines can be put into practice through decision support systems. What happens in practice can be captured through good quality electronic health record as data. And using that data, you can use technology like DEXTER to generate new knowledge that can go back into practice. So the good thing is we have all these 3 technologies at play here. So I won't go into detail because I don't want to take too much time and leave time for questions. So I won't take through this slide, but I'll take you through a few other slides. This is about how do you use computable guidelines, but I think it will take time, so I'm going to skip that. But here is a simple question. If you ask in Wave 2, are hospitalized patients with diabetes more likely to receive dexamethasone if they have COVID as opposed to people who do not have diabetes but end up with COVID? We showed in UHB data there were 2,000 COVID patients. There were 518 people with diabetes, 1,400 COVID patients without diabetes, but you can see their age is different, and so were their biochemical profile. We do what we call a propensity score matching. So now the age is similar, and so are their biochemical profile, which I'm not showing. And then you can find out what's the risk of them receiving dexamethasone. You can see that it's twice the risk. And to do the propensity score matching and do the analysis, it takes 3 minutes in this small data set. Of course, if it is millions of patients, it takes a couple of hours. So inspired by that demonstration, we now work with a maternity hospital. All of you know Shrewsbury Maternity Hospital for the wrong reasons. So when Will Perry Smith went and asked most academics in maternal health, they weren't quite keen to work with Shrewsbury Hospital. But we were very happy to take on that challenge. And the main problem in Shrewsbury Hospital was they were making the same mistake multiple times because it never was identified, and it were very much identical failures. But if you go and look at maternity data, it's the most complex data set because unfortunately it doesn't have a background ontologies. It's spread across 150 different tables, and actually making sense out of it is hard work. So what we did was working with Shrewsbury Hospital, process that data, put it into a DEXTER model, and install the DEXTER within the hospital. So you can see the data is within the hospital. DEXTER sits on top of it after it has been processed. Only there's a website for you to create a study that is outside. Everything else, the results, the data, everything stays in the hospital. Now, what they can do is, as part of some of the audits they have to do, they have to get structured data from electronic health record extracted. Usually they go and do it manually for 50 pregnant women. Now they do it for all of them. To do 50 pregnant women takes them a couple of days. Now to do the whole 2,000, it will take less than a minute. So that's the way we are helping out with the Shrewsbury Maternity Hospital. We are well aware the data quality is not that great. So every time we do any audits, we also look at the quality of the data so that we can feed that back, so that nudges people to enter better data. So that's the DEXTER Care as such. I won't go through informatics consult. This is around artificial intelligence to use to make decision. Like, for example, in Mary, who's got multiple health conditions, and like hypertension, diabetes, chronic kidney disease, and depression, which is a new diagnosis. If you ask which antidepressant we should give, we may struggle because we really don't have any evidence to know if it should be sertraline or fluoxetine, or if it should be mitriptyline or so in a person with comorbidities. So can we use data to understand which may help them in terms of, one, with the disease it is being prescribed for, two, what happens for the coexisting health condition, and three, what happens to the predicted health condition. But these are research, so I won't go into detail. And likewise, we can also be using what we call electronic health record enabled clinical trials. Again, I won't go into detail so that we can leave some time for discussion. Thank you. I'll stop there.